That way we can post it for folks who aren't able to be here. There are a number of folks who are out enjoying the current part of summer. I won't say last part. Maybe there's a little bit left, but so we are missing a few task force members today, but this will be available for them. Welcome. This is a meeting during which, as you can see on the agenda, we're going to do a couple things. We're going to review the clinical research, the work that the center has been doing to update Oregon's evidence review. They'll go through that today. Duncan's going to give an update on the equity survey and work that Rick Escobedo and Doctors Price and Silvas have been working on. Then we'll have discussion and feedback and wrap up at the end. Just want to take a couple minutes and remind folks we've got dueling processes here for those of you who've been part of this group since last year. We were directed to do two separate reports from the legislative perspective. The first is due this coming December, and that was the work from last year. That was the work to review the initial bill that did not pass and break it down into the 5 different areas of action and report on those. You've seen a draft report of that. We are working on finalizing that report now. That will be submitted to the legislature before December, and that will review what it would take from the Department of Health perspective, the Social Opportunity Program, what other states have enacted, how this proposed rule, that bill that wasn't passed, relates and compares to Oregon's bill as well. So that's the report that is in its final drafting and should be ready to go to submission early for its December due date. The second report, also due this December, is the work that this group is doing now, and that is a task force. It is time limited to really focus on the evidence supporting the clinical use of psilocybin. When the legislature passed the proviso language, they said, we're not ready to make the wellness model available. We do want to support a trial at the University of Washington with psilocybin for first responders and veterans. We do believe that work is important to support. We want to go forward with that, and we want an evidence review of the clinical indications for potential benefits and risks of psilocybin. So that's the work that this group is doing now. I want to highlight the equity piece. When we did the equity survey, as you're all aware, we could have done a better job out from the start. I want to take a moment and really thank Rick and Drs. Price and Silvas for helping us think of a better way to do that with a community mindset and focus. We don't have funding for that, but we will continue to work as an agency on how we can move that work forward, because it's important, not just for the psilocybin work and understanding from the community and the communities in which this may have been being used for centuries, and we don't really understand much about it, but also as a template and way to move forward on some of our other agency-wide equity work. So I can say that I will commit to moving this forward, looking for funding to support it, because it's important work. It is not funded as part of this proviso, but I did want to just make those clarifying remarks. I want to stop there and see if anyone on the group has any questions about that at the moment. And as you're all aware, this is pretty informal. It's kind of hard to be informal with a bunch of folks on Zoom, but please, if you have a comment or question, feel free to raise your hand, and like this to be, as much as anything, a discussion if possible. Okay, I don't see any hands. Mike, anything you want to add in terms of introduction, overview?
Sharissa, thanks. Hey, hi, everybody. Mike Bonetto with the center. The only thing I would add on, Sharissa, is just as you guys think about this body of work through the task force, just again, we've got 2 big buckets. This is the first big bucket, is this clinical research review. So part of this is, the center's been doing their due diligence of going through and updating what Oregon had done several years ago. You're going to get into that detail today. But the second body of work, which we'll have at our next task force meeting, is on the regulatory review of so how are people actually administering this in Oregon and other places. So that will be the next topic, and we'll get into that at the next meeting. But I just want you to know we kind of have these 2 buckets of work, and today is really focused just on the clinical research side. And I can't thank our colleagues enough. You're going to hear from Bethany in just a little bit. Bethany and Val at the center have really done some phenomenal work of compiling all this in a short amount of time. And I think you're going to kind of see what has been done and the future work that's in progress. And I think that'll lead to some good discussion. I think I see a hand there.
That's me. Hi, Mike. Sunil Agarwal here.
Hey, Sunil.
My question was about how we arrived at clinical research, and was that part of any of the bills or language? Okay, yeah, because I was just wondering, we do already exclude Harvard 1962 divinity school research with psilocybin in divinity student settings, and kind of a whole history of research of psilocybin effects in theological, you could say experimental theology, as opposed to experimental clinical. And I just didn't know if that we had a way to also look at the role, the research that's been done on psilocybin in other settings, rigorous, but not technically clinical.
I think, Sunil, I'm going to leave that to Valerie or others. So just a caveat with that. We as a state have an evidence-based hierarchy in Medicaid that we have to follow for payment. And the focus is largely clinical studies, not exclusively, but so we have a hierarchy. So you're going to see this follow most traditional clinical evidence reviews. That said, I know Valerie and Bethany have broadened their look, and I'll let them speak to that as to, your question. And I see Cody also reflecting that, yes, there is a lot of earlier work. So I can't speak to that. I will let them. But we have focused this per the language in our proviso, as well as sort of our laws that we follow, sort of a more standard clinical review. So with that, Bethany, I'm going to turn it over to you.
Thank you so much. And we will get around to the questions that were just asked as we talk about the methods that we used. So next slide, please. Before we get rolling too far, I would just like to say that my spouse is Government Affairs Director at the Association of Washington Business, and they lobby the Washington State Legislature on a variety of topics. His topics are related to environmental policy and water policy. The other contributors to this clinical evidence review have no conflicts of interest to disclose. Next slide, please. So today, this presentation is really intended to summarize relevant peer-reviewed clinical evidence. And the text on the slides that you're going to see, they're probably a little more text heavy than you might be used to. And part of that is it's important to hold as many details as we can about the evidence that are important for your decision making together in one place. But I also want to note that as detailed as these slides are, there is much greater detail in the report that you will be receiving this fall that summarizes all of this research. I would love it if you could note down any slide numbers that you might have questions associated with as you jot down your questions, and you can put them in the chat. You can put them on a sticky note next to you. But if you are able to note the slide number, that will help us efficiently use our question and answer time together at the end. Next slide, please. So today we'll be walking just a tiny bit through policy context, a little bit of the research background. I'll walk you through the method that we use to conduct this review, which will help answer some of the questions that were already asked. We'll walk together through the findings by the key question. And then I'm also going to briefly touch on what the ongoing trials are that are registered in the National Clinical Trials Registry, so that you have a sense of what we might expect to see in the next 2 to 5 years in terms of publications in this area. And we'll close our time together with a discussion. After I have given you a little bit of an overview during that discussion time, we'll open the floor up for some questions. Next slide, please. I wanted to give you an idea of where we're going. And there are two major pieces that we'll be touching on today. One is an overview of the findings from the Oregon Rapid Review that Mike mentioned a little bit earlier. And then I will also be talking about the Rapid Review update, which is essentially a description of the articles that have been published with clinical controlled trials between that Oregon review, so May of 2021 to this May, when we conducted our search. So about 2 years worth of new evidence. So you can see that there's some evidence from both the publications prior to 2021 that psilocybin use may reduce depression and anxiety, including during palliative care or end-stage cancer, end-of-life care. I do want to note that any findings that you see summarized here are based on really a limited number of studies that all have very short follow-up. So that could be a few hours, it could be a few weeks, or up to about a year. So we noticed that there's additional evidence related to reducing depression and anxiety, that the organ review noted some evidence for reduced problematic tobacco and alcohol use. We didn't find any new evidence there. Potentially some reduction in migraine days with psilocybin use. The organ review found a number of studies related to increased spiritual well-being. We didn't find any new evidence for that area. And then both reviews focused on what some of the harms may be. So some of these short-term and long-term or rare serious adverse events. Both reviews found quite a lot of evidence for short-term transient effects that aren't particularly harmful, like nausea or transient thought disorders. But there seemed to be a minority of participants who had really rare serious adverse events, such as worsening depression or suicidal state. Next slide, please. One of our key questions was really looking for screening tools to understand who may be at risk for harms or may be well placed to receive benefits from psilocybin use. And I just wanted to note right off the bat that we didn't find any new screening tools, but we do have some ideas that we'll be sharing with you today. Next slide, please. So we're just going to place this in the policy context. Next slide, please. And essentially, we've already, Sharissa, you've done a great job setting this up. But essentially, we were asked at the center to do an update of the Oregon Rapid Evidence Review that was published in July of 2021. And it synthesized relevant studies published since we synthesized some relevant studies published since that literature search from the Oregon Review. Next slide, please. Next slide, please. So psilocybin and psilocin are psychoactive alkaloids, and they're found in approximately 200 species of mushrooms. The similar chemical structures to serotonin are thought to bind to and activate receptors for serotonin, which is why it's hypothesized to help with, for example, depression and anxiety. Next slide, please. So the number of studies related to the use of psilocybin and psilocin to treat mental health conditions has increased substantially in recent years, perhaps due to the Federal Drug Administration granting breakthrough status in 2018 to a synthetic psilocybin for the treatment of major depressive disorder. A number of RCTs and other study designs have included participants with depression, anxiety, substance use disorders, OCD, PTSD, and other chronic conditions. Next slide, please. So that Oregon Rapid Review, I'm just going to give you an overview of what it was trying to do and what it reported so that you have an idea of the foundation that we're trying to build on. So the key questions focused on risks and benefits of controlled and unsupervised psilocybin use for selected conditions. And they wanted to know whether the risks and benefits might vary by personal or clinical characteristics. So personal characteristic might be type of diagnosis, and a clinical characteristic might be like a dosage amount. Yeah, we're also looking for available risk assessment tools for patients and providers, as well as what the benefits and risks were of different sources of psilocybin. And they were looking for randomized control trials, as well as systematic reviews published before May of 2021. And just before I start summarizing what their findings were, they ended up finding 4 clinical trials with participants with depression, 1 trial with individuals with OCD, 3 trials with individuals with end-stage cancer and depression, 2 trials with patients with substance use disorder, 1 trial with individuals with migraine headaches, and then an additional systematic review that summarized 10 RCTs evaluating long-term changes in spirituality after psilocybin use. Next slide, please. So at a high level, based on those 11 clinical trials, as well as that systematic review of 10 trials, they concluded that psilocybin was effective for reducing depression, anxiety, and overuse of tobacco and alcohol when used under clinical supervision with co-occurring counseling. And that last bit is really because those studies had clinical supervision and there was co-occurring psychotherapy in all of those studies. They concluded that psilocybin may reduce depression and anxiety during end-of-life care. So that was the patients with end-stage cancer and co-occurring depression. and that psilocybin was associated with increased spiritual well-being. And the short-term risks included minor physical symptoms like vomiting and some temporary thought and affective disorders, such as paranoia or grief. And that the serious adverse effects that were reported in these studies were fairly rare, and they included worsening depression and anxiety. Next slide, please. The Oregon review didn't identify any validated risk assessment tools for evaluating the likelihood of individual benefit or risk for potential psilocybin use. And then they also did end up compiling a number of commonly used screening practices that were intended to include participants who might have a higher risk of adverse effects that have emerged through clinical practice. Next slide, please. The Oregon review had a large section based on the different sources of psilocybin. And essentially they said that the controlled trials typically reported using biosynthesized psilocybin, and that uncontrolled or observational studies reported mushroom consumption as a dominant source for unsupervised settings, and that the concentrations of psilocybin and psilocin varied across the dried mushroom weights in summarized studies. But they noted that it's important to know that there are established methods of analyzing concentration and potential contamination in commercial products, which is one of the reasons why they had looked at whether there was a difference between biosynthesized or commercial products. Next slide, please. Importantly, the review noted that the controlled studies often exclude participants with comorbid medical and psychiatric conditions. And this could really limit the generalizability of the findings beyond populations that only are experiencing one of these conditions. Additionally, there has been a lack of diversity in the study populations of the summarized studies, and this is really to say that most of the participants have been typically white, college-educated, and cisgender men. Next slide, please. I also want to note that neither that Oregon review nor this present update of that review were scoped to search for or summarize the knowledge and experiences outside of published scientific literature produced in a clinical setting, and that the perspectives and experiences of Indigenous communities and other non-Western communities and institutions typically are not represented in that published scientific literature. Next slide, please. And one more. So I'm going to go ahead and walk you through the method that we used. We used the same key questions as the Oregon review, as this was an update. So you can see the conditions listed on the slide that we were really looking for, of which populations we wanted to find information about with the use of psilocybin. So this first question is really about controlled settings. And there's also a sub-question that's not here on the slide, which asks, how do the potential benefits and risks of psilocybin differ by population subgroups, including but not limited to dosage, psilocybin source, age, setting, co-ingestion, or personal characteristics? Next slide. The second key question is basically the same as the first, but looking for information about use in unsupervised settings. Third question was about the patient or provider risk assessment tools. And the final question related to the relative potential risks of different sources of psilocybin. Next slide, please. So in the top half of the slide, you'll see that we updated the searches from the Oregon Rapid Review. So essentially our search covered from January of 2021 to May 2023. We always look for that little overlap to make sure that we're not missing any studies. They had already searched Ovid Medline, PsycInfo, and Cochrane Library. We did the same, but we also added the database Porta Sophia. And then the bottom half of the slide, we also added hand searching the selected journals, which are the top 4 journals in this field related to psychoactives and psilocybin use. And we looked for any studies published between January 2021 and May 2023 in those journals. Next slide, please. And this gives you an idea of how those search results move through the process. And on the next slide, we'll talk about how many search results we had. Once the searches are complete, we review the abstract for all of those results. We review the full text of any publications that look like they might be relevant to answer any of the key questions. Once we identify the publications that are definitely relevant, we assess their methodological quality, and then we summarize the relevant results in the rapid review update. Next slide, please. So you'll see there was just under 300 results across the different sources that we were searching. And there were 13 publications that we found to be relevant to include in this review. Next slide, please. So at the Center for Evidence-Based Policy, we used a standardized process and forms across all of our projects to assess the risk of bias. So when we talk about something as having a low risk of bias, we're noting that there's clear reporting of methods and mitigation of potential biases and conflicts of interest, as opposed to the moderate or high levels, where in a high risk of bias, you might have clear flaws that introduce serious bias and threat. And I want to note there's a note at the bottom of the slide. We have a clinical evidence methods appendix in our final report, and that has detailed information about the tools that we use to assess the risk of bias. Next slide, please. All right, one more. So today we're going to be talking through two groups of information. We have some publications from trials that related to psilocybin use in supervised settings, and a couple that related to use in unsupervised settings. You can see if you skim along this slide that a lot of the studies really focused on depression, with a couple on cluster headache and migraine as well. Next slide, please. So let's go ahead and start with key question 1. And again, this is really looking at the benefits and risks of supervised use. Next slide, please. First, we found 2 systematic reviews that evaluated psilocybin for depression, and both of these reviews had low risk of bias. These reviews included some of the publications that we'll talk about in just a moment, as well as publications from the trials that were addressed in the Oregon Rapid Review. And both of these reviews noted that there was definitely short-term improvement compared to placebo for some of the participants in the trials, but that the follow-up for these participants was fairly short, typically less than a year, and that it wasn't clear if the benefit for participants using psilocybin for depression was sustained beyond, say, 3 months. Next slide, please. So now we're going to transition to talking about individual RCTs. So we assessed this first RCT as having a low risk of bias, although the study sample was not diverse and the follow-up period was brief. But this study enrolled 52 participants with major depressive disorder, and the psilocybin group had a significantly greater reduction in depression scores, and about half of the psilocybin group were considered to be in remission at a 14-day follow-up. So the authors of this RCT concluded that psilocybin was associated with a very quick, relatively quick reduction in depression. Next slide, please. This next RCT compared a high dose of psilocybin, which was 25 milligrams, and a low dose of psilocybin, which was 10 milligrams. And the placebo had 1 milligram of psilocybin, which they didn't expect to have any particular effect. It enrolled 233 participants with treatment-resistant episodes of major depression, and noted that the high-dose psilocybin group had a significant decrease in depression compared with the control group 3 weeks after administration of psilocybin. So again, a relatively quick-acting reduction. But they did note that this decrease was not maintained at the 12-week follow-up. So there were 79 people who were inside of that high-dose group, and about a third of them were treatment responders, which means that they had about a 50% decrease in depression scores. About a third were considered to be in remission, meaning that they had very low depression scores, and 20% had a sustained response through week 12. About 1/5 of the participants in the low dose and placebo groups were responders, and less than 10% were considered to be in remission. But I wanted to put that bullet there just to note that there's definitely an expectancy bias when it comes to psilocybin, and that's noted in a variety of articles as well. And it's one reason why it's so important to include control groups. Next slide, please. In the Oregon Review, there was a description of an RCT. Oh, we're just going to wait for that slide to come back. I will just carry on.
Thanks, Bethany. Yeah.
All right, there we go. So there was a 12-month follow-up to an RCT that was previously summarized in the Oregon Review, and it reported on both intervention and waitlisted groups. So the waitlisted group served as the placebo group in the preliminary study. In this follow-up, all of the participants were given psilocybin. So there were 24 participants that had major depressive order. The doses were weight dependent and co-occurred with psychotherapy. And about 3/4 of those 24 participants had a 50% decrease in depression symptoms, which again notes that they are treatment responders. And about 2/3 of the participants were considered to have attained remission.
All right. I don't know if everyone can see that, but we've been attacked by pornography. And I'm not sure how to quite get rid of that. Perhaps we, why don't we all get out? Let's leave and then rejoin the meeting and see if that doesn't help.
If you kick Alex out, we're looking at Alex's screen.
Yeah.
Is that Alex? Okay, then let's just
And-
kick Alex out.
And lock the meeting and make
Yep.
it so that only the host can share their screen.
Dorothy Ann, can you do that if you haven't already?
Also, it was Thomas that did the typing earlier.
Okay. Thomas, where is Thomas? I don't see Thomas in here now.
He's gone.
Okay, thank you for keeping track of that. Thank you, Donnie. So let us
Can I
know.
share my screen again?
There's a person, Samantha P075. I'm not sure who that is, but they just joined as we kicked out Alex, just so you know.
Samantha, can you please let us know who you are?
And they're gone.
Nicely done. All
So
right.
can we lock this down now?
I may have to send out a new link.
You should be able to lock the meeting in the security settings.
We've got a couple people joining right now, so just
Yeah, so let's do this. Dorothy Ann, how about if you send a new link to the group on the agenda? And
oh no, not again.
Yeah.
yes, so let's log out. Dorothy Ann, look for a new link from Dorothy Ann. We will.
Bethany, I see John has his hand up. John?
Thank you, Mike. Go ahead, John.
Thank you, Dr. Godlewski, if I pronounced your name correctly.
Yeah.
I don't have a slide specific question. I'm sorry. I thought there was a long enough pause and then I went ahead and raised my hand. Is that okay?
Yeah, of course. Go ahead.
And actually I have 3. So I'll just say, so will we get a written copy of this to review, Bethany?
Yes.
And secondly, then, when this report goes forward, are we, I guess this is for Teresa, are our names attached to it, or is it simply saying that we have accepted this report or received this report from Dr. Godlewski and colleagues?
I think that's something we can talk about. I mean, what we did with the last report was listed the members of the task force. I think if, I'm happy to represent it however the group wants. If the group says, yes, we heard it and we, do or don't agree, that's fine. I mean, we can talk about that. I don't know that we've made any decisions around that, John.
Okay, and I don't really have, Bethany, I don't want you to think that I was setting it up that I wouldn't want to be associated with it. That wasn't the case. I was just curious. My last question is not really a question, I suppose, but more of a suggestion. The adverse event profiles and frequency, I wonder if to contextualize those, it would be worth including comparable rates for some of the common antipsychotic drugs that are used, just to provide some context for these outcomes.
Thank you, John.
And I'm sorry that happened while you were presenting. That's maximally disrespectful to you, and I apologize.
At least it was the first time it's ever happened to me too. Could have been worse. I also noticed that Lisa Price has a couple questions in the chat, and I'll go ahead and address those before we take another question. So the synthetic versus whole mushrooms, you'll have to go back to the Oregon report for that. A lot of the considerations that they were looking at related to potential risks of contamination, for example, of mushrooms versus synthetic psilocybin. And I don't think that there have been head-to-head studies in that report either, comparing the two.
And my question is how these findings on synthetic molecules are going to inform the legislature on the use of whole mushrooms. So not so much what's been found, but you've got a report here, and this information is on synthetic, which is going to differ from the whole mushroom, right? And so I'm wondering, when this report goes to the legislature, how are they going to use this information? I mean, I would think that they would come back and say, well, this is great. These are synthetic molecules, but we need to know what we're doing with the whole mushroom. And then my second is that maybe this is a good gateway to making a statement in the report about that the state needs to really open up access to whole mushroom research and making it easier for researchers like Dr. Sackett to get these mushrooms, and Paul as well.
Thank you, Lisa. I'm not sure how this will be used by legislators. I also do not include recommendations inside of the reports that we do at the Center for Evidence Policy. So that's my answer to that question.
But Lisa, we can certainly discuss that as a group and highlight gaps that we want to present as a task force to the legislature. That is our purview, and we can do that as we develop the report.
And then just to address the other couple questions that you had noted in the chat, Lisa, the retrospective surveys, the two that we just talked about in unsupervised use setting, that was basically the best that we could get in terms of information about unsupervised use. We would have preferred to only have any sort of control on these, or any sort of prospective studies, but they're just not available right now. And then in terms of the serious adverse events, the best estimate is none of the studies had more than 10% of serious adverse events in terms of participants. So hopefully that gives you sort of a ballpark range. All right, thank you. I see a few other people with hands up. I'm going to start in the order that I see you on the screen. Donnie, would you like to ask your question?
Yeah, so my question starts on slide 32, but I noticed it on other slides as well, which is I didn't see it listed how many psilocybin sessions they had in the study. And I also didn't notice it as a key question. And I'm curious if it is data that you're tracking from study to study, or is it one psilocybin session or is it multiple? And if there's any differences that you've seen between studies that have one session versus studies that have multiple sessions.
So that level of detail is included in the report, and I'm glad that you called it out. So you can look forward to that. I'll call out a couple things. First, for the depression, the studies with participants with depression, it was typically 1 dose or 2 doses that were separated by about 2 weeks. In the cluster headache study, you saw that there was 5 serial doses. So it varies, and in the trials that are ongoing right now, it varies as well, but predominantly there's 2 or 1 dosing sessions.
Thank you.
All right, and Cody, do you have a question?
Yeah, so of course, I'm not sure if this is in the purview of what you're doing right now, but, I also think it's very important, at least in this case, we're not just strictly dealing with clinical trials for, just a prospective medication, but also one that is currently a criminal offense to possess. I think it's also important to include, not just what are the consequences of, these clinical trials, but also what are the consequences of not doing anything, of not taking action, and if the legislature were to choose that. I think there are other confounds here, and also in the same context, I would also be very curious to compare, like, for your average clinical trial, what is the rate of the number of successful studies that show, okay, there's this drug shows some efficacy, versus the number of false positives. Okay, well, we thought that it turned out that we found this drug doesn't have any meaningful clinical result. And what if there's like a data set out there that is able to that looks at that, and to compare psilocybin in these clinical trials of psilocybin to what we would normally expect. So we have some priors that we're working off of to come up with better estimations as to whether or not the legislature should take a course of action on this. I don't know if you plan on including that, or if that's ever something that you include. But I think having some priors to work off of is probably important in this instance.
Thank you, Cody. I see one more hand up.
Yes, Bethany, it's Sunil Agrawal here again. Thank you. My question was, is there any way to get access to monitoring data from the Oregon Health Authority related to their ongoing psilocybin services that they're doing? And, I remember the first session was in Salem, and it's that kind of setting that they're doing, that they're doing down there is very close to, what would be closest to what we might set up here, or at least what was envisioned in the last round of meetings that we had. And I know that they're doing some kind of monitoring of, adverse events or something. And it seems like it would be very logical to try and collect that data, or at least see if we can learn from it and share it with our legislators. Have you looked into that?
So that is outside of my purview, but Mike, I'm wondering if that has been considered as part of the other bits of this project.
We haven't, Sunil, but I think it's a really great point, and one that we should probably tap into OHA and just see what they've got available. I know obviously we got service centers that just got up and running, but to see what information could be available that we could kind of include in the report and show to you guys, I think is fair. So I think it's a fair reach out for us to do to OHA as a follow-up. So thanks for that. Yeah.
And I just want to note the article that Sunil referenced in the chat, that our gold standard of approval in this country is the FDA, and the FDA often approves things that don't work, and so it becomes much more complicated than this. But I do like your point, Cody, of saying drugs are approved in this X range just for comparison's sake. I think that's a useful point to make.
Yeah, that was just an example of a big study that came out earlier this year that really did shake up a little bit of that. So it's important to put that in perspective, because legislators may not even know that. And I think it's important.
Hey, Bethany, I was just going through my notes. Seth, if you're on, you had a comment on our first session on slide 8. I didn't know if you wanted to talk to that. You had a reduction in physical pain is missing. Didn't know if you wanted to reference any research there or wanted to talk about that.
Yeah, thank you for that. I don't have any research right here available for me to share, but I'll certainly look that up. At low doses, not microdose levels, but maybe 3 to 4 times higher than a microdose level, there was definitely a reduction in physical pain, and that lasts 3 to 4 hours. And I certainly think that would be a positive contributor to the reduction of opioid use. And I just wanted to make sure that someone noted that. It was just something that to me was glaringly missing off of that slide. But I will look at some research items and forward those along.
Great. Seth, appreciate that. Thanks.
UC San Diego has published case reports on phantom pain reductions with psilocybin. I forgot the researcher's name there, but they were kind of the first formal documentation of that. This has been known for a long time, but those formal cases are out there. And now, of course, the ongoing clinical trials. But I don't know if you include that level of, N equals 1 in your study, although I think it is for that patient with a severe intractable phantom limb pain, it changed, it definitely, there was an effect that was documented, and it's evidence. But I don't know if that fits the rules of evidence here.
Thank you, Sunil, and thank you, Seth. If you do know of controlled clinical trials that relate to that, please do pass them on. Case reports are not eligible for inclusion, neither are single-arm studies. And in fact, I've heard a variety of comments that continue to reinforce the importance today of using some sort of control group, whether it's a placebo or a waitlist or something else, especially related to the expectancy bias. As you noted in the large study of major depressive disorder, about a fifth of those in the placebo group were noted to be responders, meaning without even ever touching psilocybin, they noted a 50% or greater decrease in their depression symptoms. And so it's really important to have some of those comparisons in place.
Yes, I just wanted to clarify. Of course, in pain, it's a little bit different, chronic neuropathic pain. And also these are N of 1 where you do on and then off and then on and then off. So there's a structure, and a lot of, people who do qualitative research, there is a great value in that to understand, especially we're dealing with such a psychoactive complex thing here. I really feel like, we got into a lot of problems last time trying to kind of medicalize this and demedicalize this, and there's all kinds of and ultimately in Oregon, this is not a medical model they're doing there. And I want to just make sure that we use we have other ways of learning and knowing about this beyond the sort of RCT. And I think it's important that we try to broaden our ways of knowing this, because it's obviously, there's limitations in this way of understanding. That's what I.
Thank you, Sunil. And I did want to note that actually one of the RCTs that we found in the ongoing trials does address chronic low back pain, which may or may not be the same as those case reports that you were noticing. But I would say that we may have within a few years a publication that does have some sort of greater control and supervision around pain and psilocybin use.
That's the Berkeley study. Yes, that's great. I'm excited to see that too.
Hey, Bethany, while I've got you on and everybody, I was wondering, can I just, Dorothy Ann, can I share my screen real fast? I just wanted to do just a quick pivot, and it kind of gets to John's point. Thanks, guys. Let me just pull my screen up. John, you were asking earlier about, so are we signing off on a report? I just wanted to highlight the actual language that you guys have been tasked with. So I just highlighted this in blue here. Reviewing the available clinical information around specific clinical indications for use of psilocybin, including what co-occurring diagnoses or medical family histories may exclude a person from use of psilocybin. So this is kind of this overarching body of work that, the center has undertaken, and really kind of piggybacking on what Oregon had done, and then looking at populations excluded, discuss factors considered when approval of a medical intervention is approved, consider the diversity of participants in clinical trials and the limitations of each study when applying learnings to the population at large, and identify gaps in the clinical research for the purpose of identifying opportunities for investment by the state, for the University of Washington, Washington State, or both consider study. So this is, I think, again, as you guys look at this, you're now coming forward with recommendations saying, hey, we understood, here's where we are, but here's maybe where we need to go. And I think I just want to make sure that we're all on the same page on that. Because I think Bethany's trying to kind of be very diplomatic, and there's a lot of limitations there, right? And I think your job is to understand, okay, well, what do we want to do to start looking at things differently within that body of work? And not to put anybody on the spot, but Nathan, you're on, are you not?
I am. Hello.
Hi. I'm just kind of curious, as you kind of go through all of this and the position that you're in with UW and starting your body of work, any kind of thoughts from you?
Yeah, I think first off, Bethany, good job on the review. I think that was a nice summary of a lot of different papers. A few different thoughts. One thought that comes up, which is an ongoing challenge in all of this work, is that we're trying to use regulatory and kind of administrative frame to measure, evaluate, and assess a treatment that fundamentally differs from most treatments, right? It's both a mix of psychotherapy and psychopharmacology. It is incredibly, even the idea of adverse event monitoring is very challenging, because there's a lot of evidence to show that it doesn't, that the adverse events that someone reports doesn't necessarily correlate to the clinical outcome. And so I just think there's a lot of messiness with the system that we have. And so that's something that's highlighted. The two other points that I want to bring up I totally agree with Dr. Price, this issue of the source of the psilocybin. I think that's a huge gap in the literature, and that we're making this inference that the synthetic molecule somehow can be extrapolated to extend to the whole mushroom, which, you know, may be true, but we really don't know. And that's a big leap in logic. And I think ideally it would be great if we could create a system where the state could explore using the whole mushroom, since that better reflects what most people are going to continue to use. And then lastly, in the issue around inclusion criteria and the diversity concern, again, because this treatment, I think, is so fundamentally rooted in kind of cultural history, the risk of bias is quite profound. And that risk of bias, I think, is amplified by cultural nuance. And if we don't address issues of diversity in enrollment in these trials early on, I feel like that gap is just going to become harder and harder to fill. And so I really hope that we as a state take on a more proactive approach in figuring out how we can enroll a greater diversity of patients early on in these studies. Yeah, so those are the 3 points that I would make.
Nathan, thank you for that.
And thanks to you, Mike, for clarifying my earlier question, responding to it.
Great, thanks, John. Other thoughts, comments, feedback for Bethany?
Bethany, thank you for the comprehensive overview.
And I guess I would kind of lean on you guys some more. So after this, you'll get the slide deck. If you have time, you want to go through this again and then provide any written feedback around, again, what I just had outlined in the task force scope. So are there limitations? Are there things that we should be thinking about differently in terms of the research? Because that is what we want to include in the report. It's not just, you know, signing off on Bethany's report, but it's really understanding kind of where should Washington go next regarding research. And that's where we would love your feedback and input. Yeah, Paul.
You're muted, Paul.
So sorry, I'm a klutz. I want to support Lisa Price's advocacy for a separate group to study certain minorities and ethnicities. One of the things that's really obvious from these clinical studies, the majority are white people, Caucasians, and I think arguably you can make the case that marginalized communities suffer greater depression, greater anxiety, could have greater benefit. I would expect that the clinical results would even be more extraordinary with minority populations. And then I'm going to say something controversial because I like to just float these ideas to see what the pushback is. It's always educational. In the diversity equity group that Lisa Price is suggesting, I think there should be a Caucasian member on that committee. Why? Because I think those of us who are Caucasians don't fully appreciate the struggles that minorities have. For instance, for my grandson is half Black. I'm faced with all sorts of issues about him walking down the street with a hoodie on, warning him that the cops could profile him and they wouldn't profile me. So I'm just saying, having also a member of the Caucasian race in the diversity equity committee could be important for saying, wow, in my subculture, I don't get exposed to this. So anyhow, I think that having the minority committee is really important. I think Lisa makes a good point. And I also suggest that committee contain a non-minority member whose reflection and prejudice may show bias that needs to be considered. That's all I wanted to say. So,
Paul, thank you.
I want to note Darren's points that in research studies where BIPOC folks are included, they are paid both for their time and transportation. And we at the agency are looking at policies to implement to do that when we bring in folks for, surveys or stakeholder discussions. And I think overall that's what we should be doing. But I do want to note your point. And I think all of these comments and points that you're making are exactly the things that belong in this report, that we need to highlight to the legislature, because arguably their view, at least to date, when they think of sort of the clinical piece, they think, the way in which it's been framed forever. And so I think these are really important points that we can bring up as part of the legislative report to get them to think more broadly, particularly since there's so much interest in a wellness model beyond just the clinical model.
Any other thoughts, comments on this before we pivot?
Yeah, well, just but the wellness model, and of course, that was the whole thing. And I'm just curious, like, it seems like the legislation was written as more the medical model side.
Yeah.
That's why those questions were there. But we spent all our time last year talking about the wellness model, and none of that, like, where did that go? Like, it didn't go anywhere. And now we're kind of trying to fight the same fight. So I think that I feel like somehow there was some loss of, money and energy and work that didn't go anywhere. We're just curious if you have any thoughts on that.
I think, I've worked for the state for 10 years, and I would be remiss if I said I understood how the politics work. I don't. That said, I think that my impression from talking to some of the legislators was they didn't have enough grounding in the benefit of psilocybin within sort of the normal construct that they think of a clinical model. And because they couldn't wrap their heads around that, the thought of just making it available for a wellness model and the sort of scars they had left from the implementation of the whole cannabis, rollout was challenging and problematic. And we heard that it very much poorly served communities of color and that whole rollout. So I think it was a combination of things. So, I think it's lack of knowledge, just sort of, we don't want to repeat that whole process. It didn't go as well as we would have hoped to. So I am hoping that providing this clinical information, as well as sort of the gaps and needs that we're all identifying, will help them move beyond just, okay, let's make it available for Nathan and the UW to study and others, WSU. But I think more importantly, what's Oregon going to show us, and be able to bring that information to the legislature to say, look, there are other places doing this. I think the other thing is that there is a lot of people in Washington like to think that Washington is the best. And so as we hear what other states are doing and how they're more forward thinking and moving along this continuum faster than we are, when we do the regulatory piece, I think that will also be important to highlight for the legislature, because they don't want to be behind. So I think, as Senator Solomon said, this isn't going to be a quick jaunt to get us where we want to go, but I do think continuing to add these pieces of information and moving forward is, from my perspective, the best that we can do given what we've got right now.
Thank you so much for your answer. And it reminded me, the UW did announce a clinical trial of fungal psilocybin Dr. Bach is doing in a retreat center near UW with cancer patients, I believe. And they're going to be using FDA, psilocybin product from a Canadian company, Filament, and they're being funded by a private family foundation. I mean, it's sort of, I don't know if it's an RCT database yet, but it is like that's a relevant study to be in this report, because it's going to happen in this, the flagship state university, and they're using fungal psilocybin, and it's not, there's no state money. I don't know how much state funds are involved, but I just thought it's interesting to note that even if we did nothing, like, that's already moving forward in that way.
That's good to know. Yeah.
I just thought that'd be worth pointing out.
Nathan, are you aware of that study?
Oh yeah, and I'm aware of the company Filament. I'm actually in discussion with them, and we're exploring using their compound as a potential source in our trial as well.
Thank you.
Hey, John, did you have your hand raised before?
Oh, I did, and I thought I'd just save it. Thanks.
Okay. Anybody else? Guys, thank you for the great discussion. This was just the right feedback that we need. So we'll be able to go back and maybe come back with some key themes for you guys to review around limitations, or again, direction that Washington, recommendations you would be making around kind of Washington's next steps on research. Okay, can we bring back up the slide deck and let's take a look at Duncan? I think you're up, correct?
Yeah, I am. And if it's easier, I can share the slides. Whatever works.
Sure. Why don't you do that?
Okay. So just real quick, a brief overview of what will come next meeting. So one of the purviews of this kind of second task force session has been to discuss regulatory structures. And as Sunil was talking about earlier, what certainly was the main point of discussion last task force session was this model that was going to be implemented in Washington that resembled Oregon. And unlike a year ago, we are at this opportunity now where the Oregon model is operational and all the rules and regulations are worked out for the most part. And we have a chance to review those in depth as a group and give our feedback. And so what will be happening in between this meeting and the next is you'll be sent this survey that kind of picks apart all the rules and regulations that exist from Oregon and kind of puts it into a survey that allows you to give feedback and either support or disagree with all these different aspects of rules and regulatory structures that Oregon has implemented. And I expect it to be 20-30 minute survey. I think it would be really valuable to get your feedback in whatever form, and we can compile it, and that'll give us a really nice set
Duncan,
of
I'm gonna interrupt you. We're gonna work hard of getting that to 15 to 20, just so you know. We're gonna do our best. We've got some work to do, but we want to make this sure it's as efficient as possible for you guys. So yeah. Thanks, Duncan.
Yeah, absolutely. So 15 to 20, and it should give us a good set of data to kind of present to the legislature, and I think it'll be a really interesting discussion next work group meeting.
That's right. So that's going to be important for you guys to complete, because that will be a bit of the foundation for our next meeting, to kind of go through those results and have some open discussion with you guys around pros, cons to a lot of the Oregon work.
Absolutely.
Okay, Duncan, I think you're still up.
And so next, as we've I've been involved in this equity subcommittee. With Dr. Escobedo and I have been working on this one, failed to both reach the populations that we wanted to reach, or even any population at all. And also certainly the questions could have been phrased better. So just a brief history, and then I'm going to hand it over to Rick. Basically, last session, one of the tasks that this work group was faced with was analyzing the social opportunity program, which is in 5660, which is a bill introduced by Senator Solomon that failed, and kind of working on it, developing it, seeing if it would be viable to in a future psilocybin program, and if it was going to be effective in supporting BIPOC communities. And so that part of addressing that directive that the work group was given was to create this equity survey, but the equity survey itself was not specifically given to this work group as a directive. It was more the work group's choice to kind of incorporate that as a strategy. There's a low response rate. The demographic was primarily white. And so Dr. Price, Dr. Silvas, and Rick Escobedo kind of are the members currently that propose to reintroduce the survey. And we are in the midst of doing that now. And so we can go to the next slide, and I will hand it over to Rick from here to kind of give a rundown of what we've been working on so far et cetera, et cetera. Rick, are you ready?
Yes. Thanks, Duncan. You guys hear me okay?
Yeah.
Yeah, okay. Yeah, so I'm zooming in. If you hear some background noise here, we're at a family cabin here on the First Nations land of Okanagan by Mount Vernon. So there's tons of family and kiddos running around. So if you hear them, please excuse that. So I've been part of this on the public comment since the beginning, off and on in my schedule. Has kind of pulled me in different directions with work, but now back on, and I came more involved with this equity subcommittee when I take a look at the survey that was put out. And initially, Dr. Silvas and I looked at it and looked at how it can be improved. Looked at other surveys where we're being out to going out to marginalized, underserved communities, and started to discuss how we can do this better and be proactive and really learn from our neighboring partners in Oregon. And so so we decided to look at this and look at really the Berkeley psilocybin survey that came out a while back, and that's through the Berkeley Center for Science and Psychedelics. And just full disclosure, I wasn't part of that survey project, but I am currently onboarding to be a mentor for those students in that program, if possible other work down the road. So we looked at that and used it as a template. It was a lengthy survey. It was mostly distributed by, I think, via online, and all specific to, can't remember the number of folks they got there. But we did create an outline and contact to distribution strategy to diverse groups in Washington State. And I was looking at the slides, and I don't see them now, Duncan. You muted, so maybe you can put them up and maybe help me go down the list. Oh, thank you.
Sorry about that.
If you just want to skip to either the second or third slide we're on. There we go. Thank you. Oh, one more.
All set?
I think just go back one. There we go. So looking at diverse groups in our state and looking really how could we reach them, so this work has been really looking at identifying what data is most pertinent and important to discuss with the legislation, discussing budgeting needs, and creating a survey. So we have a good working survey questions, and we're still waiting to hear back from the Berkeley group on more about their survey and budget. And really looking at implementing an adequate contact and distribution plan. Our goal is to really coordinate and disseminate the plan on a really good timeline. What we learned from the Oregon folks is that it was also short, not enough folks involved, so we didn't get a good results with that. Next slide. So my previous work with the working under the migrant education health program, which is a K through 12 really program that supports migrant agricultural and tribal communities engaging in work that we're looking at issues to really help support the mental health needs. And after a long time of advocating, say 3 or 4 years, we were able to get more funding, about $560,000 to communities that are eligible. And we need to figure out what our community needs, because we have these ideas of what should be included in a survey, but really using a framework and using clinical settings and really educational institutions are using now the MTSS model, multi-tiered systems of support. We use that as a kind of a basis for really surveying agricultural tribal communities within school settings. And this is a model that it can be really used to the work we're looking at. But it's really the framework would be working with community health workers that are centered and employed through public health centers and community health clinics. They are trusted folks working in the communities, well respected, and they're a very diverse group. So, I mean, outreach and education, CHWs would be doing is some education on the SB 5660, of course, the social opportunity program via Zoom. This is a training that would be laid out to really initially start this survey to our marginalized communities in both rural and urban settings. Providing a historic context of use of mushrooms within indigenous communities, psilocybin research and advice care, mental health disorders, and substance use disorders, and a training on how to facilitate a community-centered survey with group settings and individuals. And we talked about really community centers, town hall meetings, and how with BIPOC communities, a qualitative system of approach with gathering surveys, it's best used and works a lot better. So in a group setting, doing this in that way. Okay. So we did meet with Angela Albee from Oregon, and she's a manager of Oregon Psilocybin Services Program, to kind of discuss their equity efforts. And we had a great meeting with her, shared lots of good things that we're doing. And of course, where we're looking at focusing on those areas of improvement. You know, how can we do things better, of course, and what we should be considering. So they distributed Oregon distributed a community interest survey in 2022 to demonstrate interest in the legislator. Because they had lower participation, and it was a random distribution from BIPOC folks. And then it was really, to be frank, she had said it was due to the history of harm and violence in communities. So hard to get good survey questions and really how you implement that distributed and who is the folks doing it. It's really has a big way of saying what are the results going to be. So her recommendations were really to tether data collection to equity goals early, right? Which we're starting to do now, and certainly can go forward with this if it's well supported. Oh, so my slides disappeared.
Did we lose Duncan too? Beth, would you mind pulling yours up?
Yeah, we'll do. Just give me a quick sec.
Thanks.
Yeah, I can go off mine, but not everyone will be seeing the slides.
No problem, Rick. We'll pull that right up.
One sec.
There you go. Thank you.
Yeah, of course.
So just go one forward, I think.
Yep, sorry.
And we get on to yep, keep going. One, there we go. Thank you. So her recommendations are really to take together to collection of equity goals early, right? Engage directly with community leaders. It serves as a way to build trust, right? If you don't have a trusted community member really helping facilitate this, well-known person, then your results are going to be minimal. And then be careful on how you make promises to community. be wary of losing trust. Clear communication to participants on how the survey data will be used, expand subcommittee to better represent a greater range of communities. Next slide, please. So, I mean, what can we do better? As we started to talk this and listening to Paul and Dr. Sackett's recommendations. Thank you for that, by the way. Currently the subcommittee is Dr. Price, Dr. Silvas, and Duncan. So really looking at and we've been volunteering for this work that is very important, and we need to look at really how can we allocate resources for the creation of the survey and distribution plan if we really want results, and look at hearing from our communities that have been underserved and marginalized. We really need to put the effort into this, right? When it comes to the word equity and home equity, everyone's wants that and supports that, and then here during the pandemic, COVID-19 pandemic, everyone was really into and wanting the sweat equity, doing home building projects, but it's different, very different to when it talks about people and really being inclusive for some reason. So hoping we can really work towards making this better and really educating the legislator why this is important, and really being not the best Washington State, but being a good example of how we can look at bettering studies and focusing on communities, BIPOC communities. So really allowing a reasonable timeline and support to work financially and labor-wise. There's training involved, there's outreach, there's more training, and then there's surveying and with a team of folks, right? And the piece that follows that. So, I mean, all folks should be psilocybin informed. If they're not, it'd be good to get up to speed on some of that, and really possibly hiring equity contractors who are psilocybin informed to work on this project. Must be an integral part of the legislation process at every point. Next slide, please. So, I mean, what we've learned from our work, our communities, and really what Jessica Albee has shared with us in Oregon, it's really our recommendations are to formulate a permanent equity subcommittee within the Department of Health, and that can help ensure that equity is continually considered. Both Oregon and Colorado have equity subcommittees responsible for conducting research and providing recommendations to their programs. Expand the committee, particularly with BIPOC prospects that are psilocybin informed, equity, and committee oriented. Allocate defined resources for creating data to inform equity policy, and this meaning a budget to develop, translate, and distribute. Create equity survey with allocated resources, train facilitators, data analysis reporting, followed by a new set of directives. What are we going to learn after some of this data that comes out? And also, people work on this project to be psilocybin informed and associated with community. So engaged and connected with community somehow will be key. I think that's it. Maybe there's one more slide there.
Nope, I think we're just going on to discussion.
Yeah, thank you. I just want to say again, thanks, Duncan, for supporting us with this work in early communication and collaboration. And Dr. Price and Dr. Silvas is not with us today.
Rick, thank you so much for the overview. Darren, I saw you had a few posts in the chat, but I welcome your thoughts, other thoughts from the group on kind of progress made, thoughts about kind of these next steps.
I don't have any specific thoughts beyond what I posted. I mean, I've been in communication with Lisa, Dr. Price, with some of the key points that need to be hammered out regarding the equity piece. So I'm willing to help in any way I can. I know that that's a very important document that needs to be produced. I'm happy to do it and happy to help out whoever needs help in doing it. So we ought to be working collaboratively to get to produce something nice. And we have enough evidence now to know what sort of the emerging best practices are tending to look like as we move forward with this new profession and this whole new endeavor. So however I can help. And the Center for Novel Therapeutics and Addiction Psychiatry is willing to do whatever we need to do to help the state to accomplish these goals. Thank you.
Darren, thank you. Really appreciate that. And I guessing you're going to get looped in sooner rather than later on this. So appreciate your.
That's fine, Mike. Thank you.
That's great.
Thank
you. Sharissa, any thoughts from you just from an HCA perspective, kind of next steps here?
Yeah, I do. I think, thank you, Rick and Doctors Price and Silvis. I think, and Duncan as well, I think it will be informative for us at the Healthcare Authority to hear what the budgeting implications were from the Berkeley study. I actually see the framework you've developed, Rick, or you've worked with and are recommending that we use to move forward as being more broadly applicable than just to this work. I think as an agency, we struggle with this all the time. We've got all the science and the academia, which we know is not reflective of the vast majority of people whose voices aren't usually heard. And this seems to me to be a pathway to help enable the voices of others to be heard, and it's structured and led by community. And so my thinking as I hear you is as we get the budgeting, can we, and we're not funded for this work now, but I do think it's worth us taking back internally and talking about, is this a model we want to go to the legislature and say, we have a vision for how engagement and survey work with the community could be done. And we would need to fund a community group, I think it was in the chat, to do so and to honor people's time and their expertise. And I think developing some sort of framework to have that done on our agency side to pair with the sort of traditional academic clinical piece really would do a much better job of reflecting all the voices, both the quantitative and qualitative out there. So in my just listening to you, that's kind of what I'm thinking with this, is I see this as a possible way to, have a more ongoing way in which we can fund community to do this kind of work, starting with this as a pilot, for lack of a better word. But certainly something we can take back and talk about at the agency level. But we want to make sure that we're focused on the equity, mindful of having the expertise that's necessary to both engage the community and understand what's being asked and needs to be answered, but also then bring that back so that we can present it with the right view towards the legislature so that they are hearing and understanding what we're trying to hear and understand.
Yeah, thank you for that. And it's important to notice that, our state is certainly doing some good work, and there's been some proclamations in 2021 by Thurston County Board of Directors, how they have addressed and have said there is serious issues of racism and discrimination in their systems. And so has, King County, who've actually went beyond putting a plan together, but putting up 25 million to really address, some of these systemic issues. Thank you.
Anything else on this? Quinn, I saw you clapping. I didn't know if you wanted to add anything from your perspective from the HCA lens.
Hi, everybody. I'm Quinn. I'm the Health Equity Director for the Washington State Healthcare Authority. Sharissa and I were just messaging each other on the side a little bit ago, and I don't have anything else to add to what Sharissa has said other than that I fully support that, and we'll look forward to seeing more on how HCA can help move this work forward. We want to be sure that we have the proper experts in the room to bring this work forward, but not just experts in equity alone or psilocybin alone, but both, and finding someone or a group of people with that kind of expertise in both is kind of like finding a unicorn. So I would be all in support for finding those unicorns that we can. And then if we're unable to find people who have expertise in all of it together, we can bring in people with a little bit of each side, bring them together and see if we can make something happen. But I'm sure there are some people in this room who are experts in both. But if we want to bring in community voices and having the communities be at the forefront of leading this work, we're going to have to support them in various ways, financially and in systems. So yeah, that's why I clapped. I'm like, yes, Sharisa, 100%.
I want to take a moment. I know that it was mentioned that the Department of Health have an equity group, and I see Lacey Fehrenbach from DOH is on, and I know that the Department of Health also is leading a huge amount of the equity work in the state, and it would be nice for us if we can share ideas or collaborate. We don't want to pepper community with 5 different state agencies all asking the same question. So Lacey, I don't know if, I know I'm putting you on the spot, but I don't know if you want to say anything or not, how we might, think collaboratively about this, or just, pause for thinking and we can revisit it later.
Yeah, we have the Community Collaborative, which has over 700 organizations from across the state that participate, and they participate largely based on interest and focus on whatever the issue is at hand. That group meets at least monthly, so I'm happy to work with Sharisa and our lead from the Equity and Social Justice team at DOH to see what's possible about getting in front of and engaging with that group.
Thanks.
I just have a comment and then a question, is that there are, I hear a lot that there are not BIPOC people that can be involved in this work, or that they may be rare. And I would like to challenge that thought, and maybe we stop saying that, because BIPOC people are out there that are psilocybin informed and that are involved in this. And so let's just kind of pull back from saying that, because I think that limits us in getting people involved. So Carissa, the question that I have is that since now there is a recommendation for establishing a permanent equity committee alongside with this legislation, what happens next? I mean, yeah, what happens next with that recommendation or that suggestion?
So what will happen is that recommendation will go into the report. Then we as an agency have a process that we can use to request funding for things. And we've already missed the supplemental budget discussions start in January, and we've already missed all the deadlines for requests. So I think what we would probably do is continue this work, see what the final recommendations were, engage Senator Solomon, let him know what the task force is talking about. That's something he could move forward. But also, I think, as I mentioned, this to me seems to be a way to, a good broad-based way to use community, to engage community. And could we ask for legislative funding to support our agency, I don't know, grant, I don't know the right word, but having some community based organization or group lead this work around a particular subject. So that's kind of how I'm thinking we could move forward with it, is really to sort of ask for funding to pay folks for their time, including you all, but we don't have that now. So that's sort of how I'm thinking we might leverage this discussion moving forward.
Other thoughts, comments here? Guys, we've got about 5 minutes left, and we're happy to let you go early, but at the same time, I know there's been a few folks I've just been watching. Brian, Todd, Jay, Seth, who else was on here? Who we hadn't heard from today. If there's any kind of, as you guys were thinking about today, and you're kind of heard clinical research update, equity update, kind of knowing what is next. Any thoughts, questions, comments from you guys who haven't spoken yet today? Caitlin, I saw you too, sorry.
Other than to emphasize Lisa's last comment there, in terms of that engagement piece, I always feel like my job here is to give the warnings of cannabis, and that one is one really big one that we can do a better job at here with psilocybin.
Great, thanks, Caitlin.
Hi, Mike. Brian Jansen. I love the equity piece. I'm trying to frame in my head, where does something like First People's ancient wisdom traditions fit into the BIPOC language, right? Because we have thousands of years of experience, and it seems like the first peoples are the first place to start. So, and you know, it's odd because I'm like a 6'6" Dutch guy, very white, and I'm here representing an indigenous tradition, which is not really race specific, right? It's in Brazil, which is, if there was ever a rainbow, Brazil is it. And so I don't quite have the distinction between indigenous, I'm indigenous, okay, but so there's just some things that aren't clear, in my mind at least, that I think are relevant.
Got it. Thanks, Brian.
Brian, I think you're right. And one of the things I've learned at the state is that when you do things like this, you learn how many gaps you have and what you're not able to do well. And I think that, you know, the presentation that Bethany gave us, you know, it was a very academic focus. So how do we bring in the voices of the indigenous communities? And maybe it's part of the work that Rick talked about, and maybe it's not. But that these discussions afford us an opportunity to be able to say, here are gaps and groups that we are not able to hear from. And so, and how we get information from those different communities may be different, but I do think, you know, you make a good point. How do we assure that the voice of folks that we want to be heard with millennia of experience or centuries are able to be heard? And I see Darren's clarification. Yes.
And Catherine, I saw you had your hand raised.
Yeah, thank you very much. I just wanted to kind of follow up on what Caitlin said. I'm the research manager at the Liquor and Cannabis Board, and we just recently stood up our social equity and cannabis program. I'm happy to share our experiences,
that'd be great.
The gaps that we experienced in bringing community into the conversation. We'll know a little more once licenses begin to be issued towards the end of the year, but I'm happy to share that. You know, our experience there, what we saw as wins, what we saw as absolute things we need to work on in the next round of licensing. Again, from the cannabis side, and I know that's different, and I want to acknowledge that, but just happy to share that moving forward. Thanks.
Yeah, Catherine, that'd be great. We would certainly appreciate that. Thank you. Sharissa, we're about out of time. I just want to clarify maybe two pieces of work for task force members. So as Duncan mentioned, you're going to have a survey that is going to be based on kind of an Oregon regulatory framework, and we'll be asking for your feedback, right? What you like, what you don't like. We're going to take those results. We'll compile those. We'll have that discussion with you at our next task force meeting, which I believe is set on October
5th.
October 5th. Thank you, Dorothy Ann, very much. On October 5th. And at the same time, as you get this slide deck that Bethany just went through today on the research, again, what we are asking you guys to do is to give us feedback around what limitations would you like to see kind of removed, and, you know, based on even populations that have been studied, based on anything else around kind of these clinical trials that we've reviewed. So you have the opportunity to kind of tell the Washington legislature, hey, if we're going to do future research, we should be looking at X, Y, and Z, or doing this differently. So we really would love your feedback on that. Yeah, Sunil.
Yeah, just the language of traditional medicine is really helpful to start using that as the international standard. The WHO, World Health Organization, really is trying to make a push globally for governments, including our government, to take that into consideration. And so I just sent you a link here for this. They had this first summit in India recently. It's happening. It just happened last week, I guess. And it's part of a big launch they're doing all around with this center. So that's clinical. That's medicine. Traditional medicine is medicine, and that traditional practices are relevant to clinical practice. So we can take that language and use it the way that we understand it. And I certainly learned traditional, complementary, and alternative or integrative medicine in my University of Washington Medical School. So if that's what they're saying about clinical studies, I mean that's relevant to that's a clinical study. Medical school is anyway. So just try to think about that and see if maybe we can address those. Those are the ways you can talk about those gaps, the traditional knowledge.
Oh, that's a great way to frame it. Thanks, Anil.
Yeah.
Okay.
Everybody, I see we're losing folks to competing meetings. So I want to thank everybody for your time, for tolerating the interruption of our little commercial break. And we will meet again in October. Rick, Lisa, Dr. Silvas, again, thank you for your work with Duncan on this. And Bethany, thank you for the excellent overview. You'll get slides and we'll have more conversations. So thanks all. Have a good rest of the afternoon.
Thanks, guys.